Good evening. Okay, good evening. Thank you for inviting me here once again, Dr. Yakovo. So in the next few minutes, I'm going to present you a quite, I would say, a case that we often see in our patient clinics. And there are patients that at some point we don't have anything else to do with them. Diuresis doesn't work, so we have to think forward. So the patient is a 70-year-old male, rather slim. He reports shortness of breath and minimal exertion the last 6 months. He has multiple admissions for decompensation. In 2014, he underwent a coronary artery bypass with 2 grafts, and he has also multiple ablations for atrial fibrillation and SVT. So in 2020, he had also an iliac bypass surgery, and he suffers from hypothyroidism, hypertension, and dyslipidemia. So this was the ECG on admission. It's a normal sinus rhythm with a good ventricular rate, and his chest X-ray. So this chest X-ray, I need to mention, is after the patient was admitted in another hospital, and he was hospitalized for 10 days, and he received very intensive diuresis. So in order for us to be as much as possible fit for the intervention. So these are the medication he is on at the moment of the admission. Apixaban, furosemide, rather small dose. You can appreciate eplerenone, petaxolol, ramipril, felodipine for his hypertension, amiodarone, atorvastatin, lansoprazole, and T4. His renal function was rather good, and his BNP was 247. And this is the baseline transthoracic echo, where you can see that the LV is rather small with good function. But this is not the case for the RV, which is dilated, and you can see the gap, the coaptation gap between the leaflets and the massive tricuspid regurgitation. With an arrow of 1.6, a regurgitant volume of 82 ml. So LV, as we said before, good function, small size, RV, huge, with and diastolic volume of 160 and systolic volume of 80. And this is the baseline TOE we did for the assessment of the patient. The left ventricle, as you can see, is small with good function and with a mild mitral regurgitation. And then we do the sweeping for the tricuspid valve. In the tricuspid valve, you can see a central jet with a radius of 1.2. The transgastric views, these are really helpful to locate the jet. And when it comes to transcatheter right repair of the tricuspid, it's very important to have good transgastric views. And in this case, we were quite lucky with that. Again, more views of the tricuspid. And 4D views, we can see the coaptation gap and the jet that comes. Radius 1.2, coaptation gap 0.6. Patient, because he had a coronary artery bypass, we had to see the grafts as well. So we did a coronary angiogram. In the previous slide, I'm sorry, you can see. In the previous slide, you could see the RCA was not dominant, and you can see the graph to the LAD, which is good, but this is the graph to the OM, which is probably closed in the beginning, and there's a retrograde flow. Right heart cath, rather low pressures in right atrium, right ventricle, and with a mean PA of 14 and a wedge pressure of 9. So we have a patient, 70-year-old, with all these comorbidities we mentioned before, and left ventricular ejection fraction 55%, dilated RV, impaired systolic function, huge regurgitation with a central gap, bilateral dilatation, mild MR, and an RVSP of 40, which is probably an underestimation because of the huge tricuspid regurgitation. So the Euroscore 2 was 5.95, and the TRI-score 14%. Which makes him having an intermediate risk for surgery. So the heart team decided that the patient should probably benefit from an transcatheter edge-to-edge repair. So these are the inferior vena cava before while he was intubated, which was quite dilated, and the RV annulus dilatation. Again, more views of the tricuspid valve, just to locate the Z, and where should be oriented the device. In this image, you can see that something pushes the wall, the RV wall. This something is probably the sternum of the patient, because he had the pectus excavatum. So probably it's the pressure that the sternum applies. We don't really know if this has anything to do with the tricuspid agitation. So multiplanar reconstruction of the valve. Huge jet, again. And this was with blood pressure of 90, because the patient was intubated, as we said. Again, the gap. And so we decided to go with Pascal Ace device, and this is the device inserting the right atrium towards the tricuspid valve. So initially, we decided to go more commissural, I would say, but this was not the ideal location. So the residual regurgitation was quite big. So we removed the device, and we forwarded that more, I would say, posterior septal, multiple attempts. And this was a more, ideal, but not ideal. So we still had regurgitation of more than 50%. So we consider that the operation is successful when we have like more than 50% reduction of the initial regurgitation. So we decided to go with another device. So at this point, we decided to go more anteroseptal, just right to the previous one. And at this point, I need to say that the operation lasted 3 hours. We had so many attempts, independent grasping, but finally, we had this result, which you can all appreciate that was quite good, with only mild residual regurgitation. And more images. And we can see that we have a good grasping of the leaflets. And this is the fluoroscopy with the two devices. And the patient was admitted, was discharged on the second day post-op. And he came like 2 months in the outpatient clinic, and this was his transthoracic echo with the mild residual regurgitation. And you can see that the tricuspid regurgitation has previously had a more triangular signal. This is the signal we know in tricuspid regurgitation Z. So this is it. Thank you so much.
Thank you, Dr. Kourkouvellis. So this is a good example of when to do a procedure where, it's not a futile patient. We're talking today a lot about, and Dr. Dangas was talking about hepatologists, but this is a clear-cut case, a good coaptation gap, despite, it was not an easy procedure. Most of the times in TriClip, you needed to place two Pascal or two clips, I suppose, right?
Yeah.
So, and most of the times you don't get to have this kind of beautiful result. George?
So it was a nice, an excellent contribution to this scenario. Well, probably the RV dysfunction had to do with the ischemic substrate, not with the volume overload.
Yes.
So in this scenario, we had a combination of dysfunction in RV due to the chronic ischemia.
Or, sorry for the interruption, because of the multiple episodes of atrial fibrillation. So maybe he had a natural functional regurgitation.
No, because the indices of the RV was decreased.
Yes, that's true. That's true.
And also it was impressive that even the TAPSE was eliminated, and the strain was pretty. So it was an obvious dysfunction of the RV, which could not be the outcome of the tricuspid regurgitation.
Yeah, I know what you mean.
So in this scenario, I think it's irrelevant, the quantification of the TR.
Okay.
If you have this kind of RV, you have to be more aggressive to intervene.
Yeah.
It's something which should be taken into account in the real world. And another point is, how do you explain the low level of BNP?
Because as I mentioned before, the patient was admitted for 10 days in another hospital. He had a BNP of, let's say, 800 to 900, and he received like Simdex, I don't know why, but he did, diuresis like over 200 milligrams per day. So when he came to us, we wanted him to be like dry. So I think it was like a false, let's say, normal, sort of normal.
So, and George, have you ever seen pectum excavatum to
Yes, it's
to get implicated with this kind of?
Well, I didn't want to make these comments more complex, but you irritate me. Actually, when you have this kind of pectum excavatum, there is always malformation of the annulus, of tricuspid annulus. And there is always an amount of tricuspid regurgitation. It is a fact. But in this scenario, the key point for your decision should be the RV dysfunction.
Okay, yeah.
Because having this background of the in the case that we had a properly functioning RV, I would be, hesitant to intervene with the same color of TR.
Of TR, okay. Yeah.
Dr. Katsianos has a comment.
Thank you, Yota, for the great presentation. I would just like to comment. The TR era is an era that we're gaining experience every day. There are a lot of options in terms of interventional therapy, TR, TTVR, and as Dr. Halapas mentioned before, the cardioband, which maybe in the future could be a good option, leaving other options open. So, in my opinion, it is very crucial to choose the right patient for the right therapy and the right time, as you said before, to treat the patient with the good therapies that we have in option.
Yeah. That's a great comment, and all of the, many of these devices, like the cardioband that has been mentioned, it has been tried, very difficult to place, very cumbersome, but at the end of the day, it's a part of a solution. And anyway, this valve, it's not the aortic valve, like the mitral valve as well, so it's even more difficult to be treated. Donny, you have a last comment?
We hear an excellent case, fantastic result, great heart team work. Sometimes the problem with the tricuspid valve is imaging. In that case, we didn't saw that, but that's an issue in these TR procedures. And just I want to say that the comment by Dr. Athanasopoulos was really excellent. Another issue is the pulmonary hypertension that must be taken into account. And finally, that it is not sometimes necessary to proceed with right heart catheterization in order to evaluate and estimate the pulmonary hypertension in such cases. Excellent case, excellent result.
Okay, good.
So I will take the opportunity, since Dr. Halapas made an excellent comment concerning the dynamics, the RV dynamics, the pulmonic pressures and resistances in this area. We see quite often patients with severe TR having at the same time high wedge of around 30, plus increased pulmonic pressure around 50, 55, 60. In this scenario of an increased wedge around 30 and pulmonic pressure, secondary pulmonic pressure of around 50 to 60, how this data affect our decision-making for tricuspid interventions?
So, because the tricuspid regurgitation is not a valve issue, we need to find out what causes the tricuspid agitation. So if the tricuspid agitation and the pulmonary hypertension has other causes, we need to focus on these causes. If it's another valve, we need to focus on the other valve. If it's pathology, like ischemic etiology or anything like that, we need to focus on that. So to be honest, when we have a patient with tricuspid agitation, having or not having a pulmonary hypertension, because sometimes we don't have, like in this case, high pulmonary pressures, we always need to find what causes the tricuspid agitation. In this case, you mentioned correctly, it was the RV per se. It might have a word to say the pectus, it might have a word to say the annular dilatation of the atrial of the valve, but when it comes to tricuspid agitation, we need to see the whole thing, and not only the valve. Because if we fix the valve and we haven't fixed the problem, the valve will come back again as a problem.
Good. I think we'll have to leave it there. Thank you, Yoda.
You're welcome.
Thanks a lot. So, Dr. Pagiannakis is not available because he has something